I'm oral historian Mike Chappell. Today, June 23, 2012, I'm interviewing Dr. Zvi Laron for the Endocrine Society at its annual meeting being held this year at the George R. Brown Convention Center in Houston, Texas.
I was shown 3 children who were very dwarfed and obese and had hypogenitalism. They looked exactly like children who lacked growth hormone. They had a tendency for hypoglycemia, which was typical for growth hormone deficiency. So I was certain that they have growth hormone deficiency and started to give them growth hormone, and they did not respond the way I expected. The moment it was 63, it means almost 5 years later, we could measure their growth hormone, and to our astonishment, we found that they have extremely high levels of growth hormone, the same as acromegalic patients. So we were very astonished and said, well, this seems to be a new disease. And we published, it took us 3 years to publish that, until we really could do more studies on these patients. And we had two possibilities, which were the 2 ideas. One was that the molecule of their growth hormone is abnormal and therefore biologically inactive, or that the tissues do not respond to growth hormone. And we showed that their growth hormone in the blood, that means minute amounts, bind to the receptor in a similar way as we measure the growth hormone by radioimmunoassay. This and other immunological tests proved that their growth hormone, their circulating growth hormone, is normal. And so the next step was to show what happened with the resistance. Now, the receptor, we had to test their receptor, the receptor of these people. Now, we know that growth hormone produces IGF-1, which was, as I said, sulfation factor, and with DOE we showed that when you inject growth hormone in these patients, their IGF-1, which is produced in the liver, does not rise. In contradistinction, children who have growth hormone deficiency, IGF-1 rises. And IGF-1 is the effector hormone of growth hormone on the tissue and especially on the bones. So I asked permission from 2 parents to take by operation a liver biopsy from these patients. They permitted, because I told them that without knowing exactly what the disease is, we cannot really hope for a treatment. So they permitted, and we were able to show that their membranes containing receptors for growth hormone did not bind growth hormone. So we knew that the receptors are defect, are pathological. But we still didn't know, 83, we still didn't know what was wrong. Because only in 1989 was the receptor completely cloned, and the structure was elucidated by Dr. Godowski, and we participated in that. He worked at Genentech at that time. So we were able at that time to show better what is wrong with the receptor. Now, we knew nowadays, we knew at that time that their defect is in growth hormone receptor. They are growth hormone insensitive. And the only drug that would be possible to give is IGF-1. And in 1987, IGF-1 was biosynthesized in Japan. We received from Japan the first clinical samples in 1989, and started to treat the children. We were the first to treat children with IGF-1. So we have accumulated the largest and longest experience with IGF-1 treatment. Now, in addition to treating a certain number of patients, we were able to learn the pharmacology of IGF-1 in children. That means, what does IGF-1 do? What effects does it have on carbohydrate metabolism, on protein metabolism, on the kidney, on the heart, etc.? And we have summarized 50 years of our experience last year in a book called Laron Syndrome from Man to Mouse with Dr. John Kopchik